Let's be real for a second. If you're a medical student, an anesthesia resident, or really anyone managing patients in critical care, you know that interpreting an arterial blood gas, an ABG, can sometimes feel completely overwhelming. It's kind of like trying to read a foreign language under immense pressure, right? But today, we're going to translate that language. We're going to demystify the notoriously complex world of acid-base physiology for your critical care shifts. And we're not just going to memorize numbers. We're going to make these concepts completely intuitive by breaking down the microscopic mechanics, the actual physiological gears turning inside your patient's blood vessels, lungs, and kidneys that are actively keeping them alive.
So, here's our roadmap for today. First, we'll cover why acid-base balance actually matters. Then we'll spend some time demystifying pH and hydrogen before diving into acids, bases, and ions. After that, we'll tackle the infamous Henderson-Hasselbalch equation, and finally, bring it all together with clinical ABG interpretation.
All right, Section 1, why acid-base balance matters. Seriously, why is our body water so completely obsessed with hydrogen? It's a fundamental question, because even the tiniest changes in hydrogen ion activity act as massive, blaring alarm bells for acute illness. Think about it. The human body is mostly water, and the electrolyte composition within that fluid is incredibly tightly regulated to maintain homeostasis. Alterations in hydrogen ions, carbon dioxide or bicarbonate, they never just happen randomly. They're actually the most critical indicators we have to assess a patient's respiratory and metabolic status. They guide our life-saving treatments and really predict the severity of the illness we're dealing with. To understand this, you have to realize that the body's water is strictly divided. It maintains a distinct homeostasis inside the cell versus outside the cell. Inside the intracellular compartment, things are actually relatively acidic, hovering right around a pH of 6.8. But outside the cell, in the extracellular fluid, which crucially includes the arterial blood we draw for our ABGs, it's relatively alkaline at a pH of about 7.4. So when we talk about clinical acid-base balance and draw an ABG, we are primarily measuring that specific extracellular arterial blood environment. Moving right along to Section 2, demystifying pH and hydrogen. Okay, so what is pH, really? Essentially, it's a mathematical concept that measures the exact activity of hydrogen ions in our system. Because hydrogen ion concentrations are so incredibly tiny, using raw numbers would be a total nightmare for clinicians. I mean, imagine trying to chart those decimals. Instead, we use pH, which stands for the negative logarithm of the hydrogen ion concentration. It's brilliantly dubbed the power of hydrogen. But here's the catch, and you always have to remember this, because it's a negative logarithm, as the amount of hydrogen ions increases, the pH number actually goes down. Think about this contrast in scale for a second, because it literally perfectly illustrates how tightly the body guards free hydrogen. Imagine a single liter of extracellular fluid. Within that 1 liter, you have this massive ocean of about 55 moles of water. But floating around in that ocean, there are only about 40 times nanomoles of active hydrogen ions. That is a billionth of a mole. It's an infinitesimally small amount. The body goes to absolute extremes to protect that microscopic ratio. Why? Because human enzymes and proteins will literally denature, change shape, and fail if that tiny 40 nanomole count fluctuates too wildly. And remember, that water isn't just static. It's engaged in this continuous dynamic balancing act. Water molecules are constantly splitting apart into acidic hydrogen ions and alkaline hydroxide ions and then reforming. In pure water, this auto-ionization creates perfectly equal concentrations of both, making it totally neutral. But the human body isn't pure water, right? It's a complex circulating soup tightly maintained around 37 degrees Celsius. That means any shift in this dissociation process reflects a very real and potentially dangerous acid-base disturbance. Let's step it up a bit. Section 3, acids, bases, and ions. Our understanding of exactly what makes an acid and a base has evolved over time. The classic Arrhenius definition simply focuses on chemicals releasing hydrogen or hydroxyl ions. But the more universally applicable Bronsted-Lowry definition, it looks at this whole process as a microscopic game of hot potato with protons. Acids are the donors, they're throwing the proton. Bases are the acceptors, they're catching it. And what's amazing here is that water can act as both. It's amphiteric. It's a physiological chameleon that can jump in and act as an acid or a base, depending entirely on what the body needs in that moment. Now, let's talk about pKa, which is simply the pH level where exactly half of a given substance has broken apart or dissociated. This concept is a real game changer for understanding clinical labs. For example, a strong acid like lactic acid has a really low pKa of 3.8. Because our blood pH is 7.4, lactic acid is way past its breaking point and exists almost entirely as lactate, dumping massive amounts of free hydrogen directly into the blood. Contrast that with carbonic acid, which has a pKa of 6.4, meaning it remains weak and partially intact. This is exactly why a septic patient's rising lactate levels directly and rapidly drive their severe acidosis.
And we can't forget the heavy hitters, the strong ions. These are fully dissociated ions that heavily dictate the final pH of that extracellular fluid. When we balance the positive cations like sodium, potassium, calcium, and magnesium against negative anions like chloride, we get the strong ion difference. Normally, this sits right around 40 to 44 milliequivalents per liter. Along with weak acids like albumin and phosphate, these strong ions are constantly exerting a massive background influence on your patient's baseline acid-base status.
Okay, section 4. It is time for the big one, the Henderson-Hasselbalch equation.
First, we need to establish a golden rule of physiology. An increase in carbon dioxide directly creates an increase in acidic hydrogen ions, period. Carbon dioxide combines with water to form carbonic acid, which then rapidly splits into a hydrogen ion and bicarbonate. Functionally, this means CO2 acts as an acid in the body. If your patient stops breathing, CO2 builds up on the left side of this equation, which completely forces the reaction to the right, dumping highly dangerous amounts of free hydrogen ions directly into their bloodstream. And that brings us to the absolute holy grail of acid-base physiology, the Henderson-Hasselbalch equation. This beautifully demonstrates that your patient's pH is basically a physiological seesaw. You've got metabolic bicarbonate sitting on the top and respiratory carbon dioxide on the bottom. Now, don't worry, you absolutely do not need to do this complex math in your head on the ward, but you do need to visualize this dynamic relationship. If the denominator, the CO2, goes up, the overall pH goes down. If the numerator, the bicarbonate, goes down, the pH goes down. It is a perfect, continuous balancing act between the lungs and the kidneys. Let's bring all this chemistry to the bedside. Section 5, Clinical ABG Interpretation. You need to lock these reference ranges into your memory right now, because these 3 variables are your absolute baseline for diagnosing your patient's survival status. Normal pH is incredibly tight, sitting right between 7.35 and 7.45. Your PaCO2, which is your respiratory indicator, normally sits between 35 and 45 millimeters of mercury. And your bicarb, the metabolic indicator, lives between 22 and 26 milliequivalents per liter. Whenever you grab a fresh printout from the blood gas analyzer, these are the anchors you will use to ground your clinical judgment. So, what happens when things go wrong? When the pH drops below 7.35 or rises above 7.45, you are immediately looking at a systemic physiological crisis. An acidic environment actively depresses the central nervous system and decreases cardiac contractility. The heart literally beats weaker. On the flip side, an alkaline environment can trigger life-threatening arrhythmias and seizures. These deviations aren't just minor lab abnormalities, okay? They are flashing red lights predicting acute illness and severe impending metabolic or respiratory failure. Clinically, there is a very distinct divide in how the body handles this. Your patient's lungs control the respiratory CO2 disturbances, while the rest of the body's metabolic system, primarily the kidneys, handles the bicarbonate disturbances. Let's say a patient is hypoventilating from an opioid overdose. They retain CO2, resulting in respiratory acidosis. But if they hyperventilate from a massive panic attack, they blow off way too much CO2, causing respiratory alkalosis. Now flip over to the metabolic side. If a patient is losing bicarbonate due to severe diarrhea, they plummet into metabolic acidosis. If they have a massive excess of bicarbonate, maybe from aggressive diuretic therapy, they develop metabolic alkalosis. It all comes right back to that physiological seesaw we built earlier. As we wrap up this explainer, I want to leave you with this. Knowing how aggressively the human body guards its 40 nanomoles of hydrogen, how will you use the Henderson-Hasselbalch seesaw to interpret the very next ABG you see? We've traced the incredible journey from the microscopic auto-ionization of pure water all the way up to complex, life-threatening clinical crises. The next time you're handed that little slip of paper with a patient's arterial blood gas result, remember the intense microscopic balancing act happening right that second inside their extracellular fluid. Are their lungs failing to clear the acid? Are their kidneys failing to hold on to the base? Those numbers are telling you a very precise story of survival. The question is, are you ready to read it?